Good morning, doctors. On behalf of Sun Pharma Spectra, I would like to welcome for last series of IFS Fertility Connect webinar for young gynecologists and the PG students. I would like to welcome our honorable speaker for today's webinar, Dr. Surveen ma'am. And madam is taking a session on endometriosis and infertility. Prisma, can I have a CV of doctor? Dr. Surveen Sindhu, she is a director and the head of IVF and Reproductive Medicine Center, Max Multi-Specialty Hospitals. And she is a professor, School of Health Science, Ansel University, having 30 years of clinical experience and authored 8 books, 4 of which have been published internationally and have over 80 publications in journals and the books. Madam is a program director for fellowship in reproductive medicine at Max Hospital, and she is the assistant editor, Fertility Science and the Research Journal. Madam is the secretary of IFS and chairperson of Infertility Committee of AOGD 2018 to 20, and she is the chairperson Reproductive Endocrinology Committee of AOGD. She is a past editor of Assistants of Obstetricians and Gynecologists of Delhi, and she is a past coordinator of Nachi Delhi 2006 to 2008. Madam is a recipient of many awards. So welcome you, ma'am, once again. And I would like to hand over the session Dr. Surveen Sindhu.
Thank you, Prachi. Thank you for the kind introduction. So, without wasting time, let's go on to our talk. Basically, I'm going to talk about endometriosis and infertility, but in the beginning, I'll be doing a little bit of general talk. So this talk, basically, after the general talk, will cover the medical treatment in infertility, the surgical treatment in both mild endometriosis, whether we should treat surgically or not treat, all the debates I'm going to cover. Whether surgery would be appropriate in infertility in grade 3 and 4 endometriosis. All parameters are compared with IVF outcomes as they tell us an appropriate fertility outcome. So it could be an IUI, but basically one is just taking the outcomes from IVF so that you know the fertility outcomes in this whole process. So we all know endometriosis is defined as the presence of endometrial-like tissue outside the uterus, which includes a chronic inflammatory reaction with the symptoms of pain, infertility, or absolutely no symptoms at all, and a prevalence of about 2 to 10% in women of reproductive age, but a very high prevalence is seen in infertility. So the dilemma in diagnosis is that it is often very, very delayed because there is no short way of diagnosing infertility except endometriosis except invasive. So it's seen even in the West countries, the delay is from 4 to 10 years. Sorry. Just gone ahead. So in diagnosis, the presence of gynecological symptoms like dysmenorrhea, deep-seated non-cyclical pelvic pain, deep dyspareunia, infertility, and fatigue. These are the basic diagnostic symptoms. The main symptom is painful periods and maybe chronic pelvic pain. In women of reproductive age, with non-cyclic gynecological cyclical symptoms like dyschinesia, dysuria, hematuria, rectal bleeding, and shoulder pain. So basically, you have to suspect the diagnosis, and it may be a diagnosis of exclusion. So you might exclude tuberculosis, you might exclude chronic pelvic infection. History, the symptoms which I've just stated. Signs are the physical examination, which we'll go on to. It could be corroborated with imaging techniques. And finally, it has to be a histological diagnosis of the specimen collected during laparoscopy. So what are the physical findings which you find? You find, you examine the pelvis and you inspect the and palpate the abdomen. The clinician should perform the vaginal examination in all suspected endometriosis, rectal examination for adolescents or women who are not sexually active. Clinicians may consider a diagnosis of deep endometriosis in women with painful induration, ovarian endometrioma in women with adnexal masses, and endometriosis is suspected of disease even if the clinical examination is normal. Can the diagnosis of endometriosis be made by application of specific medical technologies? Now, the gold standard is a combination of laparoscopy and histology. So, if you do a laparoscopy, you remove an endometrioma, send it for histology, and you will find a typical picture of endometriosis. This patient definitely has endometriosis. In many cases, the typical appearance of implants are regarded as a proof. Like you'll see those, red spots, or you'll see the pale yellow plaques. These are typical of endometriosis. A systemic review on accuracy of laparoscopy to diagnose endometriosis was done in 2004, and only 4 studies could be found. A negative diagnostic laparoscopy was highly accurate for excluding endometriosis. So if you put in the scope and you found nothing, then this patient does not have endometriosis. A positive laparoscopy is less informative and of limited value when used without taking biopsies. So you put in a scope and you say, oh, this looks like endometriosis, so it's endometriosis, and you don't take a biopsy, it may not be confirmatory. So you have to perform a laparoscopy. These are the ESHRE guidelines. Although evidence is lacking of a positive laparoscopy without histology being proving the disease. So it is very, very important that it is confirmed by histology. And in rare instances, it is important also to take the histology because there could be a malignancy sitting there. So it excludes both. It has a dual advantage, one of confirming the diagnosis, and the second of making sure that there is no underlying malignancy in this patient. So what are the characteristic findings when you put in the laparoscope? You'll find typical lesions, a powder burn, gunshot on the serosal surface of the peritoneum. They can be black, dark brown, bluish nodules, small cysts containing old hemorrhage, and variable degree of fibrosis. They could be scarring of the peritoneum. And very importantly, they could be subtle lesions like the red implants, petechial, vesicle,
Vismay, my voice is audible? Ma'am, your voice is not audible.
Have I got disconnected from my previous?
Yeah. Yes, ma'am. Yes, ma'am.
Because my computer just blacked out and I didn't know what happened.
Yeah. Now it is audible, ma'am.
Okay. Okay. Fine. You can see now, right?
Yeah, yes.
Okay. So there are these subtle lesions. They could be red implants, they could be serous, vesicular, white plaques, yellow-brown discoloration, and even subovarian adhesions. So what does this tell us? This tells us that it is very important to have an experienced person doing this laparoscopy so that this person can spot these subtle lesions and say that yes, this is endometriosis, and probably biopsy these lesions. Now, ultrasound, rectal endometriosis. In women with symptoms and signs of rectal endometriosis, transvaginal sonography is useful for identifying or ruling out rectal endometriosis. So, TVS is important for the diagnosis of rectal, although it is highly operator dependent, and hence we do not recommend it for rectal endometriosis because not everybody is experienced with doing a TVS. Ovarian endometriosis, the clinician can, very nicely diagnose on TVS. You will find a cyst, a ground glass echogenicity, which we all have seen when we put in our vaginal probe. It may be divided into 1 to 4 compartments, but there is no papillary structure with detectable flow. 3D ultrasounds are very, very useful, and they help in diagnosing ovarian endometriosis. MRI again is, it is fairly accurate for ovarian endometriosis, but again, peritoneal endometriosis, it is not well established. What about markers, CA125, all these immunological markers? Well, they are not recommended by CDC. Can the extent of deep endometriosis be established by application of medical technology? Well, not really. There's nothing which can really diagnose deep endometriosis, but yes, one can have a try with TVS and MRIs. So coming on to endometriosis and infertility specifically. What is the role of medical treatment? It is used if you need to relieve the patient of pain. She's in severe pain, then you can relieve the patient, but the postponement of infertility therapy has to occur because both don't go hand in hand. Suppression of the disease before IVF, like many people do a long agonist protocol where they suppress the disease by giving 3 doses of the agonist depot over 3 months, and then they start the stimulation for IVF. And many studies have shown a better result. Reduction in size of adenomyoma before IVF. So if you want, there is an ill-defined adenomyoma, you don't want to touch it, but you want the size reduced before you do an embryo transfer, then you can actually retrieve the eggs, freeze them, put her on agonist, and before 3 doses of agonist depot, and then put in the embryo. Mild endometriosis. Mild endometriosis, there is no debate on whether to operate. Now you put in the scope, okay, for diagnosis, and you find there is mild endometriosis. So in mild endometriosis, there is actually no debate on whether you have to operate or not, because it is like putting in the scope and immediately coagulating the lesion or fulgurating the implants. So mild, you have to operate. Now, surgery before infertility treatment, IVF treatment like IVF in endometriosis of grade 3 and 4. So 1 and 2, we know that as we are diagnosing, we are treating surgically. The answer lies in 4 questions. In this patient, like grade 3 would be an endometrioma. That is what we most commonly faced with. Do we operate the endometrioma? Do we not operate? So let's see. Does endometriosis negatively impact the IVF? So first of all, we have to establish whether it is negatively impacting the IVF outcome. If it is, then we have to remove it. Is there any benefit if we operate before IVF? That means that on operating, does it actually cause a better result as far as IVF is concerned? Is there any harm if endometriosis is operated before IVF? So Is it going to cause an adverse impact if you operate before IVF? And is there any harm if endometriosis is not operated? So, is there harm in operating is the third question, and is there harm in not operating is the fourth question. If we answer all these four questions, we will get an answer to whether we should operate before an IVF or not. Now, let's consider first of all deep infiltrating endometriosis and then put it to one side, because it is rare, and with an infertile patient, we don't know whether what exactly is to be done. So there was a systemic review and meta-analysis in 2017 for deep endometriosis, but they found a lack of proper data and conclusions on the potential role of bowel deep endometriosis surgery to improve the pregnancy rate were really not established. So positive effects could not be excluded. But definitely, if you operate, there are major complications in morbidity, because the deep-seated endometriosis can cause a bowel injury, can cause a ureteric injury, can cause a vessel injury. So it is better not to touch these. Let's answer our first question. Does endometriosis negatively impact the IVF outcome? So let's have a look. Embryo quality, it has been very controversial. Some studies say yes, it is detrimental, like the study in 1995. There are other studies which say that no, it is not detrimental, and they examine the basic morphology of the oocytes and embryos and in women with and without, and they found no difference in the two groups. And there are a whole lot of studies which say that. Also, its effect on endometrium. Many patients are doing a split cycle. Many doctors are doing a split cycle where they stimulate, take out the eggs, fertilize, freeze. Then they give an agonist to control the endometriosis and they put the embryo back. Some studies have shown a better result because the endometriosis is controlled, and they say that endometriosis has an adverse effect on implantation. However, there are other studies which say that no, there's absolutely no effect. So let's have a look at this very, very large study which Komadaren did in 2017 with a total of 22,000 women. So there were controls without endometriosis and there were those with endometriosis. These were age controlled. So basically, as far as age is concerned, their ovarian reserve should be at par. The number of oocytes recovered was the same. Cancellation rate was a little higher in endometriosis. However, despite the cancellation rate, the fertilization rate, the number of oocytes transferred, pregnancy rate, miscarriage rate, and live birth rate were all similar. And what they found was that all the women with endometriosis generate fewer oocytes, fertilization rate is not impaired, and the likelihood of achieving a live birth is also not affected. Impact of endometrioma on IVF and ICSI. Now, let's come on to the endometrioma, whether it is going to impact our cycle on IVF, ICSI or not. What they found was that the number of follicles and the number of oocytes were similar. A systemic review and meta-analysis done by Hamadan in 2015 included 33 studies. And what did he find? He compared the impact of endometrioma in versus patients who had no endometrioma. He found similar implantation rate, miscarriage rate, lower mean oocytes were retrieved, higher cancellation was there, but no study reported adverse events such as bleeding, infection, or pain. So basically, the IVF outcome was the same, because outcome we take as pregnancy rate or live birth rate, although maybe the mean oocytes retrieved were lower. So maybe quality was not impacted. So does endometriosis negatively impact the outcome? So this is our first question, and the answer is no impact on results of IVF and ICSI as far as fertilization rate, implantation rate, pregnancy rate, miscarriage rate, and live birth rate. However, there are contradictory studies. There are studies which are showing that there is a impact. So the debate, surgery before endometriosis, the answer lies now in the second question. Is there any benefit if endometriosis is operated before IVF? So it may be sitting there and not impacting, but you say, okay, let's remove it. Now, are we giving the patient a benefit after we remove it? Let's see. Demerol did this randomized control study, and this was one of the very few randomized control studies which were done. And he took 50-50. One group was surgery and the other group was no surgery. What did he find? He found that the group with surgery took much longer to stimulate. After they had been operated, they took 14 days versus no operation, 10 days. And about 25% more dose of FSH. The number of mean oocytes retrieved was slightly less. However, fertilization rate, implantation rate, and pregnancy rate was similar. There was no difference. So why are we operating? Another systemic review in 2017. Out of the 686 manuscripts, included only one randomized control and 9 retrospective studies. Live birth rate after surgery versus conservative management, odds ratio was 0.87. That means not impacting. But the antral follicle, the mean difference count was 2. So it is impacting the antral follicle. What about day 3 embryo quality? They found no difference in the day 3 embryo quality at all. Just a minute. So after surgical treatment of all stages of endometriosis. Now, impact of surgery, 4 trials with 312 participants. This was the Cochrane, which came out in 2010. They found that cystectomy was associated with a decreased ovarian response to controlled ovarian stimulation. Number of mature oocytes remained the same compared to expected management. That means that the mature oocytes were the same. There was no effect on the reproductive outcomes. Aspiration versus cystectomy, they found that they showed no evidence of a difference in clinical pregnancy rate. But cystectomy does help in preventing recurrence compared to aspiration. So does cystectomy of endometrioma improve the subsequent IVF outcomes? So these are 33 studies. In one part of this whole thing, they compared operated endometrioma versus normal ovary. That means a patient who has no endometriosis versus operated. They found lower number of oocytes and a higher gonadotropin dose was required. Then they compared operated endometrioma versus non-operated endometrioma. In these patients, they found similar implantation rate, pregnancy rate, and mean oocyte retrieval and cancellation rate. So basically, operating and not operating is the same. And it may decrease it may increase the amount of gonadotropins you require. So for any other treatment like IUI, laparoscopy would be done to assess the tubes, and surgery for endometrioma should be done in these cases. So basically, you see, IVF does not need tubes. So if the patient says, I want an IUI, then you have to assess the tubes and you have to do a laparoscopy. And when you're doing a laparoscopy, then you will remove the endometrioma. There is no question of not removing. Is there any benefit if endometriosis is operated before IVF? So our answer for the second question is, it did not alter the outcome of IVF ICSI compared with those who did not receive a surgical intervention. However, for treatments like IUI, laparoscopy is mandated to assess the tubal status, and once laparoscopy is done, endometrioma should be dealt with. So if tubes are blocked on HSG, to proceed to IVF directly, and you don't need to do laparoscopy, and you don't need to remove the endometrium. Now, is there any harm if endometriosis is operated before IVF? So, was there any benefit? Now, is there any harm? Let's see. Surgery and AMH levels. So, 11 studies, Somalinga did a review of 11 studies in 2012, and he found that a statistically significant decline of the AMH was there after surgery. The magnitude of decline was more evident in women who were operated on both sides for endometrioma. That is natural. In another study, they found that it took about 6 months for the AMH to decrease and it decreased by 61%. The AMH level decrease was more evident when the cyst was smaller, and that was probably because you had to really dig it out and maybe more ovarian tissue was taken. The AMH was more when there was a bilateral endometrioma surgery, 67 versus 57. And basal AMH level was the only independent factor affecting the AMH decrease. So the lower the AMH level, the more the decrease occurred, more proportionately. Now, why does this decrease occur? Because we lose ovarian tissue in cystectomy. So let's have a look. Alberosi in 2009, he conducted a study where he compared laparoscopy and laparotomy and the amount of ovarian tissue which was present when you removed an endometriotic cyst and when you removed a non-endometriotic cyst. So he studied the histopath and then he found, evaluated the amount of ovarian tissue. Now with laparoscopy, he found endometriotic cyst was 65%. And with laparotomy, it was 80%. The ovarian tissue was present in 80% of cases. And the ovarian tissue non-endometriotic was less on both. So the surgical approach had no statistical impact on the conservation of the ovarian reserve. If you can see that in the non-endometriotic cyst, it was 32 to 41%, and in an endometriotic, 65 to 80%. So your root is really not making a difference to the amount which is coming out. Laparoscopy could be mildly less, but not much. Nature of the ovarian cyst is what is playing a role because of the adhesions around the cyst. So, what is to be remembered? You leave alone the small endometriomas, less than 4 centimeters, because you're digging into the ovary and you're probably taking more chunks of the ovary than in a large endometrioma. Women with a low basal AMH, leave them, just do an IVF. Women with bilateral endometriomas, again, leave them. Bipolar quadri should not be used because it causes ovarian damage. But the most important thing in all this is your surgical skill. So you cannot have a blanket rule. If you have a good surgeon, you can probably take out a 4 centimeter cyst. You can take out bilateral cysts. So it is really important to have a good surgeon. Now, if surgery is done, the patient with endometriosis should be informed about fertility preservation options. So this is very, very important. Let's say I have a 8 centimeter endometrioma and I need to operate on it. Or then I have to inform her that, look, your AMH is going to fall. Do you want that I should retrieve whatever oocytes I can from the other ovary and whatever is accessible in this ovary and make embryos and preserve them, or preserve them as eggs before I do the other surgery, because maybe you may not have an ovarian reserve later on. So this is one counseling thing which must be done. And most infertile women, when you counsel them on this risk, they refuse surgery and they say, doctor, please just do an IVF, because they just want a baby. Complications and recurrence. The other thing which you have to tell them is that if I'm operating and there's a difficult surgery, I could injure the bowel, ureter, bladder, even though I am a competent surgeon. There could be a risk of recurrence of 20%. 25% women have undergone repetitive surgery. So this is not the end of the treatment, is what you have to tell her. So is there any harm if endometriosis is operated before IVF? Yes, there is a loss of ovarian tissue, decreased response, decreased AMH, besides chance of other surgical complications like injury to the bowel, the bladder, the ureter, and in the end, the trauma of the recurrence. You've undergone the surgery and again after a year, you have so many times we see patients who were operated 2 years ago and they come and you tell them that, look, there's a cyst there. They say, we just got operated. So surgery is not without harm. Coming on to the last question. Is there any harm if endometriosis is not operated? You leave it. What is going to happen? So Somalinga in 2015, the same review, over a period of 15 years, he conducted this, 25 years he conducted this review. And the Hamadan meta-analysis, 33 studies, reported no adverse effects. But what did Somalinga analyze? If retrieval of oocytes is difficult, then to be assessed before, if it is not possible, you have to do the surgery. So this is one risk of conservative management, that you may not be able to retrieve your oocytes. What is the second risk? That the disease progression during the procedure, or chemical peritonitis, or infection in the endometrioma because you have ruptured it, or higher pregnancy complications. Now, all these are very unlikely. Chemical peritonitis is very unlikely. We make sure we give good antibiotics and don't land up with abscesses. These events are uncommon, and the number of women needed to be treated would be exceedingly high and would not justify the cost and risk of intervention of the surgery. What else? The risk of missing occult malignancy with cancer development in later life. So what do you tell her? That it is very rare, 0.8%, and it will be prevented by performing a surgery later on. Interferes with the ovarian responsiveness and oocyte competence, that cyst lying there, that is not proven, as we have seen in the previous. Follicular contamination with the endometrioma content, which can occur while you're taking out the follicular fluid, it can get. So let's have a look at accidental contamination and what it leads to. Incidence in this particular paper was 6%. Number of embryos was significantly higher in the women who were exposed, but the quality of embryos was lesser in the ones which were contaminated. The chances of pregnancy were lower by a relative risk of 0.63%. And again, the live birth odds ratio was 0.6%, which means that it was significantly lower. So accidental contamination of follicular fluid is an uncommon but possible event. I think to all of us at some stage, it has occurred, even though we avoid it, but inadvertently, sometimes we can puncture. The situation may affect the IVF outcome, but does not justify systematic surgical removal before the cycle, because the advantages are much more in not removing. So is there any harm if endometriosis is not operated? So what is the answer for the fourth question? Adverse effects like progression, rupture, infection, carcinoma did not justify a surgery, as they were uncommon and the number needed to treat is large. The chance of conception is not the only issue that has to be considered. Some potential drawbacks are associated, like cost, stress, surgical complications, and recurrence. To summarize, does endometriosis negatively impact IVF outcomes? Women with endometriosis undergo IVF XC had similar reproductive outcomes compared with those without the disease. Will impact the IUI results if tubes are affected. Is there any benefit if endometriosis is operated before IVF? Did not alter the outcome of IVF XC, but will help in tubal factor for IVF for IUI patients. I'm comparing also the IUI patients because this is an infertility lecture, it's not just IVF. Is there any harm if endometriosis is operated before IVF? It has shown that the AMH levels have decreased post-surgery, and other surgical complications like maybe bowel bladder injury can occur. If on HSG the tubes are patent, we try 3 IUIs before a decision for surgery or IVF is taken. Is there any harm if endometriosis is not operated? Adverse effects like progression, rupture, infection, carcinoma, follicular contamination do not justify surgery, as they are very, very uncommon and the number needed to treat becomes very, very large. So the absolute benefit of surgery for endometriosis associated infertility appears to be smaller than the previously believed. Informed consent and counseling is the key out here. Complete and detailed information on the risks and benefits of treatment alternatives must be offered to the infertile patient to allow unbiased choices between possible options. Patient must be counseled on the quality of evidence. There are not many randomized controlled trials. When one bases his life on principles, 99% of his decisions are already made. When one bases one's practice on evidence-based medicines, the decision to operate or not operate before IVF in women with endometriosis is already made. So in my clinical practice, do not operate an endometrioma. I first do a fertility preservation for the patient. I remove the eggs, I fertilize and freeze. And till I don't have enough grade 1 embryos, I do not go ahead with the surgery. Thank you so much. I think we can take the questions now, if there are any.
I would request doctors to put questions in the chat box. I would request audience to put your any questions in the chat box or comment box, please.
So if there are no questions, we can end the session.
We'll wait for 2 minutes, ma'am. After that, we can end the session. We will wait for 2 to 3 minutes. Yeah, ma'am, there is one question.
Yeah.
From Dr. Garg from Bhatinda.
Yeah.
So the role of dydrogesterone in endometriosis.
So dydrogesterone, you see, it's a progesterone. So you can give it, but it's not specific that you give it for infertility or anything of that kind. It's not going to, it's like any other progesterone. So saying that dydrogesterone specifically, I don't think so.
Yeah, Visma, can you just put the questions from Dr. Potu?
Prachi, how many people have logged on?
There are more than 100 doctors have joined, ma'am.
So scar endometriosis, the only treatment is to remove that scar. You see, you can't keep suppressing her hormonally for the scar endometriosis. So we see a lot of scar endometriosis on the cesarean scars and all sometimes. And excision is the best method here. Surgery is the best option for scar endometriosis.
Yeah, ma'am, I think there are only these questions.
Yeah.
So we can close the session. So I would like to, yeah, ma'am. On behalf of Sun Pharma, I would like to thank all the IFS team, Dr. Sudha Prasad ma'am, Dr. Neena Malhotra ma'am, and our honorable speaker for today's session, Dr. Survin ma'am. Thanks for your wonderful deliberation, madam. And Thanks for giving us a valuable time.
Thank you.
This is the last series. Yeah. Thank you.